musculoskeletal emergency. So, of course, just when you're thinking about emergencies, you're going to go back to your, what do you need to triage yourself, or what do you need to make sure if you're in a critical care situation, what do you need to send to the emergency? So, making sure that you are treating what you can, so sprains, strains, contusions, things like that, you can safely do at an urgent care. But if you need, if you don't have X-ray capabilities, or if you feel like you are going to be delayed in treatment, or that it would hurt the patient, you should send them to a emergency room. Things that for sure you should send to an emergency room are like your open fractures or crush injuries that you're thinking that the patient could have compartment syndrome. History, same with a lot of the emergencies that we see. You want to get your complete medical history, finding out how the injury happened, where it occurred, where the pain's going, when did it happen, get your full timeline, things that you would do anytime you're interviewing a patient. Things that you'll also want to find out specifically with musculoskeletal, and you may see this as well in your neurology, is finding out if there's been any loss of neurologic function for your musculoskeletal history exams. Important again is to make sure you're getting their clinical history as well. When you are dealing with musculoskeletal emergencies, you're dealing with limbs a lot of times, and patients may not be able to do stairs anymore after you see them in the emergency room. So sending them home to a apartment that's 3 stories high when they are now non-weight bearing and in a wheelchair won't work out so well. They'll come right on back. So making sure that you get a full social history, getting their medical reconciliations really important, making sure that they aren't on any blood thinners, if they are someone that's going to the operating room, making sure you know that in case you need to do any reversals. And allergies, of course, not just the medication allergies, but if a patient has any food allergies, and here, anesthesia, finding out the last time that they ate or drank, just in case you are needing to go to the OR. Checking their vitals. Vitals are going to tell you the stability of the patient a lot of times. Do your primary assessments, your MV neurovascular checks. So checking pulses on all extremities. You should always examine not only the joint in tension, but the joints above and below. We'll talk about that with imaging as well. Some terminology that you'll use when you're doing your inspection is there swelling, edema, is there bruising, ecchymosis? Is there any deformities to the soft tissue or the bones? A lot of people say that you find out the most critical parts of your examination when you're actually listening to some of the things and making the patient breathe and seeing what hurts too. But go soft when you're doing your palpation as much as possible. You are going to have to range and palpate over soft tissue and bony structures that are pretty fragile and may have been just injured. I usually go for similar to when they taught you guys to do your abdominal exams, but they teach you to do the area that doesn't hurt first. Yeah, no. So the same thing with your musculoskeletal. So go for the area that doesn't hurt as much. First, you'll just get a better response too when you're going for the area that is ouchy. Anybody know the difference between PROMs and ROMs? Awesome, perfect. And then special tests. Some of those are like if you're testing for myelopathy, different things like that, that you are going to, everything has its own name, people like to name stuff out of them. So if there is a certain area or something that you are concerned of, and we'll go through some individual scenarios, you may need to perform some special maneuvers as well. Imaging, we do a lot of imaging. It's hard to see the bones from the outside of the body. So X-rays are great at showing us bones. What's the difference between your CT and your MRIs?
Soft tissue.
Yeah, so you have soft tissue injury, or 20 years on for. Yep, you have a cord injury. Which one are you going for? Yeah, but your CTs do show you better cortical bone. So CTs also are a lot quicker. CTs, you can have them with or without contrast. MRIs, you can also have with or without contrast. As we said in our, oncology lecture, if you are concerned with infection or if you are concerned with any oncologic process, whether that is bone or whatnot, you are gonna wanna have contrast for your MRIs. Angiograms, injecting the dye in, CT angiograms, a lot of times go together. And then ultrasounds, you can also get ultrasounds of, during your musculoskeletals. Radiographs, always get two. You can get fooled if you're just seeing one side of the picture, so a lot of times you're gonna get in two shots.
AP lateral.
Yep, an AP and a lateral are typical that you're gonna get on both. We'll go through some other fun things. You're also gonna want to image the joint above or below. If there's been a mechanism of injury that's been so hard that it could break the bone, you're gonna want to make sure that you are looking at the ones above and below just to make sure that there isn't anything that get it over. You can get stress views if you have any concern for ligamentous injury. What that means is how much elasticity you can move when you are either like pulling or whatnot to get into those x-rays. And you want to have a systematic approach to how you review these. So you're not just looking at an x-ray and you're like, oh my gosh, what is this? You're going to want to make sure that you are, and we'll go through it with cervical imaging a little bit, but you're going to want to make sure that whenever you're seeing something, you have a pretty systematic approach of what you're looking at first, second, third, fourth. Rules of two, always get two pictures. If you see an abnormality, look and make sure that there isn't a second. Image the joint above or below. Make sure that you are comparing with the contralateral side. So if I'm worried that somebody has a degenerative joint on their right side and I'm not sure if it's collapsed enough that I would want to pursue something else, I may compare it to what's happening on their right. For right and left. So comparing the lateralities, comparing with old films as much as possible. It's like the best thing as far as anesthesia is concerned or as we're concerned is having the history. So how well somebody's going to do under anesthesia, a lot of times, you know, how well they did previously is the best comparison of how they're going to do now. For the x-rays, it's the same thing. Always compare with your old films when you're available. Pull them up side by side on your computer and take a peek. Ask a friend, phone a friend. If you aren't sure, make sure that you get another opinion. You'll get radiologist reads, but you won't always have them within clinics. Sometimes they're sent out. Sometimes they're companies that are living in another country, reading things from their home. So sometimes you don't always have that immediate. You can ask your colleagues or any other specialists. And if you aren't sure what you're seeing on a CT or an MRI is real, make sure you get you can get further imaging. So differences between your CT and your MRIs. So as you guys said, bony stuff, awesome to look at the CT. You can see stuff on an MRI as well. But you don't see it as commonly in the emergency room just because of the timing. The emergency room loves getting CTs because they're fast studies. The MRIs, again, think of your osteomyelitis, think of your oncology patients. You're going to need an MRI for those guys instead of just the CT. And make sure you get the whole access. So make sure you get, if it is you're concerned with a knee, don't just get a dedicated knee MRI. Get the entire leg so you can see the extent of the infection. Same thing with the spine. If you're concerned with a cervical epidural abscess, get the entire spinal access, because there's nothing worse than having to go back and after your patient's now just been imaged for over an hour, being like, so we're gonna go send you back again for some more MRI. They don't like that. Anesthesia, we kind of went over this before. You guys feel pretty good about the differences between local, general, sedation. Like Bob's, like nods, doing great. All right, so always have your working diagnosis, how you're making a plan whenever you're in the emergency room. You want to make sure that you're educating your patients, not only as far as their medications and things of what to do, but also weight bearing status or WB, their range of motion. If you need them to follow up with a specialist, making sure that you hook them up with one. They may need to be seen by physical therapy or occupational therapy. If they're doing walkers, crutches, canes. Do you guys know if it's physical therapy or if it's occupational therapy that does a home safety evaluation? Occupational, yeah, very good. Does it work as occupational therapist? Nice. Congratulations. The occupational therapists are wonderful. They're gonna go into their home, they're gonna like check them out, make sure that they don't have any throw runs and things like that. Typically think of your occupational therapist as working with the upper extremity. Your physical therapists are gonna work a lot with your crutch training and walkers and safety valves like that. You can have technicians specific to designing your splints and braces. You should always make sure you are dictating how much you want them to be wearing. Something common is okay to remove for skin checks and hygiene or things like that if it's a split or a brace. If it's something you don't want them to remove, my advice would be to cast it. RTC, what is that? Yeah, okay, so emergency symptoms, things that you're gonna be thinking about. So if it's dependent on what the injury is, but things like fevers, chills, if they've got some open wound, if they have any neurologic dysfunction, hand up yes. Return to clinic. You always want to have, it's like a little bit of CYA, but you want to make sure that you have a, if you have any questions or fears or things like that, please make sure that you follow up. Don't add CYA, are you snacking at the next? Yeah. I'm probably not allowed to swear with you guys.
Cover your assets.
Fracture.
Make sure you're not gonna get sued until you have no money left. Cover your assets.
Oh, there we go. That's nice.
I'm here for
Appreciate it. Okay. This fracture, hey, it's open fracture. Guys, it's gonna require emergent orthopedic evaluation. Open fractures always are gonna need a washout in the OR because there's such a high risk of osteomyelitis. You're still gonna treat them for an osteoporosis, which is gonna be about 6 to 8 weeks of antibiotics. You're gonna hammer toe. I wish that's for sure. There's a high risk of neurovascular injury. Again, we give you kind of a high mechanism of energy to break that bone. You are at a high risk of this. Fractures in the components of your forearm, your lower legs, they are at high risk too for compartment syndrome. Where you can see elevation, you can see possible rhabdo, you can see your potassium going through the roof, injuries to their kidneys because their creatinine starts bumping up, and funky stuff coming in their urine. Urgent stuff. This is like your fractures that are closed but are going to need going into the OR. So like if you have hip fractures, if you've got your femurs fractured, you know, basically any leg bone fractures are gonna need going in. If it is something where you want to monitor it to make sure that you aren't having any further displacement afterwards, you will want them to get admitted. If they are like a finger fracture, that's, or like a toe fracture, something like that. A lot of times those can be managed well by their primary care physician. They aren't going to need anything. Non-displaced clavicle fractures, things like that, where, you know, they may just need a sling or some buddy tape or stuff like that, where they would just follow up with their PCP. Going through some more pictures of unbroken bones. I don't think, you guys aren't really gonna determine whether or not the patient is getting admitted if you're in the emergency room, so I'm not gonna bug you down with too much of that. Just in general, when you are talking to a consulting service, you are going to need to be able to describe a bit of the fracture at some point. At least please have x-rays, but anatomically, so when you think of mid shaft, where is that gonna be? In the middle, okay. Proximal is gonna be closest to the midline of your body. Distal obviously is gonna be furthest away. So using terminology such as middle, distal, or things like, neighboring of the bones, those are always super helpful. And fracture line patterns, again, it's great for you in your terminology and your thinking, and great for your exams. Little star fracture, if you want a little star, that next bullet. Just knowing where you're at, what different fractures, but they're pretty, I mean, they're pretty self-explanatory. You guys wanna go around transverse, like if you're cutting straight through, oblique, going on an angle. Spiral fractures are gonna curve around. Comminuted fractures are when you have multiple. Green stick buckles are like at the top of it where it goes through. Green stick is where it hits on one side and it's not complete through the entire bone. Full approach. I don't remember any of that being on my hands. Handwriting. But terminology is good to know. You know what is on your stuff, this. Star, star, star. Did you guys go over Sultan Harris fractures before?
Like a lot. So many times.
Stuff that they love on exams. Like anything that, and I'm not talking about your school, I don't know what your school exam is gonna be, but in just general, like pants, things. They love classification scales or stuff that they can go through. So whatever, we have a lot of things to help remember through, but it's memorization here. Memorize your Salter Harris fractures. Know that they are pediatric populations. This is what you're really worried about because they're growth plates. Little kids are still growing. How are you guys doing on that? Your Salter Harris fractures. I mean, I can read you the slide, but you're just gonna have to memorize that.
Yes.
Okay. The other terminology that you use with the fracture, so the thinking of a fracture as being displaced, that's when it's not aligned. Angulation is what is formed from the most distal fragment of that. Axial rotation, think of like a lot of times you have that as far as spine, like if it's if there's any rotational component to your fracture. You can have fractures that will have some shortening. You're gonna know it's stable versus unstable, complete versus incomplete, open and closed. They aren't gonna test you on the antibiotics, I don't think, but if you need to know open, you're usually using first generation cephalosporins and aminoglycosides. You're gonna have to do irrigation and debridements, likely multiple of them for open fractures.
One of the things just to know with open fractures, especially in emergency room. So a lot of times with pediatric bones, right? What's one of the things that pediatric bones are really good, like known for is they're springy, right? They're flexible. So if it's like a really bad break, you're seeing an x-ray, but it does not look like an open fracture, there's a chance it did puncture the skin and then went back in. And there was, like, it may have been a drop up. So if you see any blood on the skin, or they're wearing a coat when they fell off the monkey bars, so you have to assume there might be an open fracture there, even if it doesn't look like an obvious open fracture. Does that make sense?
All right, so when you're reading x-rays, again, systematic approach is really good. Now let's go front to back, and you can what you're gonna do. So when I'm looking at the front to back, first is checking out if there's any soft tissue swelling. Why am I concerned with soft tissue swelling? Yeah, I feel like I think he's breathing. Or there is. The front line here is gonna be your front of your, anterior vertebral body, so you're gonna, I usually look first to see if the bones are gonna be aligned. There's different lines that radiology calls, they call it posterior vertebral line. Posterior vertebral line running through the back, your posterior longitudinal ligament is running through the back, and here that's really important when you're thinking of stable versus unstable fractures. Because if you have displacement in the posterior component or if there's issues in the posterior areas, you're gonna have an unstable fracture. They may require more operation. And then, checking out, making sure all of your steps are aligned in the back. Your joints are aligned in the back, and then you have your sinus processes, which are not as important. Could you guys kind of get that from over here? So anterior line is where I'm looking for soft tissue swelling. These are gonna be your vertebral bodies, your intervertebral discs. You are gonna have through your posterior longitudinal ligament runs back here. And then you are going to look in the back posterior component, so if there's any like splaying or widening up here, that's another thing where you can think there's gonna be instability. Radiology will help you a lot and repetition will help you a lot. But if you've got questions, always just ask somebody too. No, just stretching, not a question. All right, you may be asked to clear a cervical spine, depends where you're working. If somebody comes in a cervical collar from EMS, you might be asked to use this nexus criteria to see if you can clear somebody from wearing a hard cervical brace. You want to make sure that they don't have an injury. So one, a lot of times these patients are going to have, they're going to go right in for, if you're working in a trauma setting, they're going to go in for a CT. So you're going to have that one to help you. But you can't see ligamentous injuries right as much on the CT imaging, so you can palpate down the length of the spine, checking for any midline tenderness. You want to make sure that they don't have any focal deficits. Focal deficits would be like if they have weakness in one of their hands, things like that. You want to make sure that they are alert and being able to follow you. You want to make sure that they aren't drinking or having any distracting injury that can take you away from their exam. Because if their leg is like ripped off, but their neck may be broken, but they're distracted by their leg being ripped off, they may be like, my neck's fine, don't worry about my neck. They might still have an injury to that. Your Canadian C-spine roll will not be on your hands either, but also NCTs only required for minor head injuries or with patients that have, you guys remember your Glasgow Coma scale and things like that? So fun to know. And you can go through too with this. You know, I can't remember, was it on yours? It hasn't been on any of mine. But Canadian C-spine rule, so checking if they have, you know, as we age, our bones get even more brittle. So if they are somebody that's over the age of 65, or there was some sort of dangerous mechanism to their injuries, some sort of trauma, whatnot, if there's any paresthesias, tingling in the arms or legs, just get that CT scan. I feel like now people just end up getting them more than not. But if somebody's able to move around and they're looking okay, I guess that this protects you too from not getting the cervical, or excuse me, not getting the CT scan imaging in the setting. Alrighty, your Dunn's fracture. So these are your odontoid fractures. These are most from flexion or excuse me, flexion, extension, or compression. Your type ones are gonna be stable, because you're just fracturing off that little peak at the top, which doesn't really have much to do with your bony stability. Your types 2 and types 3. Your type 2, you're fracturing at the base of that process, base of the dens. This is your most common start. It's also unstable because you are able to then slide around much more. Obviously, the lower you go, if you're going toward the junction of the odontoid and the base of C2, you're at type 3, and that is another unstable. In consult, neuro, or those spine surgery, these guys, it depends on the patient population and whatnot for how you manage them. There's no set criteria for a lot, but C-collar immobilization, 6 to 8 weeks for bony time for bone healing. But say you have some, I don't know. I'm gonna pick on the guys just because that's one of my favorite things. Yeah. But you have some like 30-year-old dude who comes in and he's demonstrated while he's been in the hospital that he just keeps taking off his brace. And he's otherwise healthy and he doesn't want to wear a brace for 6 to 8 weeks. You know, you might end up using someone for that. But of course, that's going to be more of your orthopedic decision, not your emergency decision. But you can manage a lot of the odontitis in a cervical mobilization collar. All right, you are going to have teardrop fractures. So these are from extension. So remember where we were watching that line. So the anterior body is what you see coming off of here. This is all lined up. Oh, I can't see it with the light, but you can see that there is a fracture on the anterior part of the vertebral body. There's also a little bit of posterior displacement of the vertebral body in the first view. What? Here, it looks like it's the same person. So you're getting your CT films or your MRI on the back, and then what you can see is you're gonna then watch to see and get upright x-rays. So the last picture, if you've gotten a CT, why would you need to get x-rays? I've gotten a CT, I can see all the bones. Why do I need to get an x-ray? Position. Positioning of the patient. So you can come in very quiet. Very quiet. How do you get a CT scan?
You can lay down.
Yeah, you lay the person flat. How do I want to see their weight bearing? Upright. So you can see for this patient, you know, you can't see as much of the collapse while they are flat, but when they stand up, you can see the collapse down of that fracture. So if you are worried about, you know, you're gonna, with any fracture, you're pretty much gonna be, yes.
So they're upright x-rays, are they the flexion extension or just the upright?
You just get upright AP and laterals. If you're worried about, they'll say if you're worried about more ligamentous, you can get flexion extension, or like we had a kiddo the other day who, when you're trying to see how flexible their spine is to do like a scoliosis surgery or whatnot, you get like what you call lateral benders, but most of you are just gonna get AP laterals. They love hangman's and Jefferson fractures, these two. So, your hangman fractures, these are gonna be if you are getting a big hyper extension of the neck. You're gonna get then bilateral pars and articular fractures. I love arrow signs. You don't get those in the real world. But arrow signs are nice. Kind of right where those arrows go, what comes through? Hear that? It's your mouth. Somebody else, help me.
Some nerves.
Nerves and, yeah, blood vessels. So a CTA is helpful as well for these guys. Because you're gonna wanna rule out that they don't have some vertebral artery injury, right? They just have this huge mechanism that could fracture a bone. You wanna make sure it's not puncturing through any blood vessels. Of course, do a good thorough neuro exam. And you are going to keep these guys in a collar likely. And call. She worked in orthopedics and she totally put neurosurgery in all of these, but both orthopedic spine and neurosurgeons handle fractures. Jefferson, Thomas Jefferson, #1 president. I don't know if that's true, but that's how I remember things, the lateral masses of C1. You have to like have these kind of things to like, as you do your tests. Remember, because otherwise you're gonna sit there and you're gonna be like, what's the difference between a hangman and a Jefferson fracture? Or what vertebral body? You're welcome. You can thank me later when you're doing fast and you're like, oh yeah, that's the lateral masses of C1 from my Jefferson fracture. These guys are more like you were diving into a shallow water pool. That's gonna make you have these where the occipital condyle is driving into the lateral masses and you're gonna have a fracture. These guys not normally associated with a neurological deficit. You've got a lot of room for your cord on this C1, C2. Like there's a big wide opening. So you can have some neurologic injury, of course, right? It's not like definite, it's not, but you don't necessarily have that cord injury unless there's some retropulsion fragment that's going back into the spinal canal area. A lot of times if you're having enough mechanism of injury to cause these, you're gonna also have some other cervical spine injuries. Most commonly, what's the vertebrae right next to it? It's gonna be your C2. If you're pounding your head so hard to break those upper vertebral body fractures, you also need to make sure that they don't have a brain bleed or things like that. All right, push for 4 more minutes. Got this, and then I'll take a potty break. What kind of images are you gonna get for your, what kind of views are you gonna get for your cervical vertebrals 1 and 2?
Odontoid.
Come on. I can't hear you.
Odontoid open
Yeah.
mouth. Odontoid
Yes,
open mouth.
okay. As well as.
Maybe in long.
Yes, okay, why do you want an open mouth view?
So you can move the mandible.
Yeah, because you can't see it past the teeth. So you're gonna want an open mouth view to be able to see in there, to see that tip as well as to see the facet joints of your lateral masses. Some of the mechanism of injury where you hit your head, where your spine is gonna crack. Again, hard collars, if there's any ligamentous injury or you are unstable, you're gonna need to have a cervical fixation done. Neurosurgery or ortho spine. All right, and the last one I think for cervical, and then your P grade. Your glacial shoulder fracture. Not common of a terminology, but it's a stable fracture through the spinous process. And it can be anywhere throughout your spine. Why is it most commonly at C7? Saw your mouth move. No, I forgot names. Gray sweatshirt.
She's looking up, because it's like the most common.
Yeah, it's like the most palpable. It's like right here. It's sticking out in a lot of people's. So, spinous fractures as well as what other part of the spine are typically always stable fractures. Someone on this side. Someone wearing the color gray on this side. Give me a part of a bone. No. Give me another part of the bone. Huh? You're wearing gray. Oh, what part of the bone is, if you have a fracture through it, is it most commonly always stable? Besides the spinous process? You have to be wearing gray. You're wearing gray. What do you got? All right, gray and pink and red. Yeah, it's winter. Okay. Your TP fractures.
Good job,
Josh. Your spinous process and your transverse process. Think of like the bony things that are pointing out at you. They're accessory. You can break them and it doesn't really matter. And you don't even need a collar for them because there's no real instability with those guys. So I don't necessarily. I don't love this treating with a hard collar, but consult the specialist there at that point in time. Safe by the belt, you break, and then we go for a 6-5. You got 15 Minotos. Girl, you are rain, only at your lap, and you're not wearing that other strap across you, like a bag for your girl. You can have this where it's called a chance fracture, where you're gonna have so much pressure at one area that you're gonna collapse over the back. This is usually from a flexion. It usually occurs anterior to the abdomen where you were constrained, hence the whole seatbelt analogy, and where you're breaking those posterior components. You're gonna need surgery. Okay. What's that?
Transverse process. Broken bone.
What's this?
Spinous process.
Spinous process. Do I care about those fractures as much? No. What's this?
Bodies.
Vertebral body. This is gonna be your anterior area. This is gonna be your posterior area. Oh, this is really done with this. And I'm gonna research you. So, what's the difference between a compression fracture and a burst fracture?
Wish versus
Shattered.
wish versus pieces.
I'll give you a hint. I just showed you where the anterior components are and where the posterior components are.
Compression in the anterior.
So if it's all anterior, compression. Exactly how I do this too. And then if you are fracturing where it's going back towards the pedicles or the posterior component or any interruption right there where you're gonna have your PLL, the posterior longeal ligament, you're gonna think of it as a burst fracture. So peeking over here, this isn't the best example, but what do you think that one is? Compression or burst?
First.
Yeah, from this one single view, which you're never gonna look at one single view, what am I gonna put next to these? I'm gonna put a cut like this. But from this single view, it looks like this posterior alignment is intact. So I'm gonna say compression fracture. For compression fractures, a lot of times you can just brace them. There's something called a helix scale, again. Not on your stuff, but this is gonna be reading your fracture morphology, your ligamentous injury, and any neurologic injury on a scale, determining whether or not it's gonna be operative or non-operative. For unstable burst fractures, think of that posterior longitudinal, yes.
Sorry, for fractures for both the anterior and posterior parts affecting both, like, would you call it specifically compression or burst, or would you say there's both going on? Like, how would you label
Don't answer it.
it? I can't hear a question.
All right, if you have just the anterior
That's you.
components involved. So if it is, oh, you get, oh, I think erase it. If you have just the anterior components involved, what kind of fracture is it?
Compression.
Yeah. But if it goes into the posterior, it's gonna be a burst. You can only have one or the other
Okay,
in a single vertebrae. You can have a compression fracture at maybe like T12, but a burst fracture at L1.
It won't be fracture that can destroy the whole thing. The body won't be a compression and a burst at the same time.
I mean, it sounds like they're like I think you guys are thinking of a, in the terminology of like how to describe where compression's like sunken in, right? But you can have a compression deformity in a burst fracture. Yeah, it's just the segments of the bone that differentiates between a compression and a burst. And on helix scaling for that, so with this is thoracolumbar injury classification scale. Helix. You don't have to, it's not on your thing, but this is like the fun stuff that I get to do a lot because I see them come in for trauma all the time. But think about that bone again for when you're talking about the stabilization, think about that posterior longitudinal ligament. If there's ligamentous compromise or if your patient has any neurologic injuries, then you are gonna need to stabilize it. AKA fuse. If there is such a severe loss in vertebral body height. So if you've got normally your little boxes. Okay, if you now, I usually grab like a tissue box in a patient room. If you now have such severe wedging, what are the vertebral bodies gonna do? You now have a line like this, typically, they're gonna become severely kyphotic. They're gonna collapse over. So you may need to, if they have a kyphotic deformity of over 30%, you're gonna want to. You're gonna have to stabilize them. You can have compression and burst fractures in your cervical spine, you have them in your thoracic spine, you can have them in your lumbar. Why are you concerned a lot in that thoracic area? What's important there?
Rib cage.
Yeah.
Stabilizes the rib cage. Internal organ,
What are you worried about?
spinal.
Your spinal cord becoming paralyzed. Where's your cord normally end?
Oh,
Yeah. So like here. It's a little different for each person, but usually if you're in that T1201, some people in that 2 area, you're worried about the cord. Same thing for your lumbar. What you're thinking about is you are getting your, most commonly, your fractures are gonna be compression fractures. Because you can get them from degenerative changes in your spine too. Just the all around, it's walking around and pounding. Versus your burst fractures, you're gonna need a higher energy to, fracture into the posterior components. What are some symptoms that people are having, compression fractures? Neck, back hurts. They may get shorter because now they don't have as much weight in their vertebral bodies. How are you gonna diagnose most of these? As far as your images? X-ray, yeah, start with an X-ray, get an AP and lateral. Radiology isn't even gonna let you go and do an MRI scanner without getting an X-ray. Insurance is gonna say no way, not that you need an MRI anyways, but if you're concerned for a ligamentous, or if you're concerned for a neurologic injury, that you would get a stat MRI. There's differences like that if you're worried about chronic minor or something. Conservative, you can do your bracing for a lot of compression fractures. But if you are having any neurological deficits and they're unstable, then you may need to have a surgery. You can fill compression fracture bones with cement. It's called a vertebroplasty. So if you see a lot of whitening in somebody's X-ray, it might be cement. Kyphoplasty is similar to a vertebroplasty, but you're just putting a balloon in first. And then you're doing the cement into them. Yes.
Just wondering from like an emergency room standpoint, how differentiating conservative versus surgical, where are we?
Yeah, if you're going into it, I would have you look at the T-Lix scaling. But if you have a spinal fracture, you're gonna usually, but it would be, you're grading them on what type of fracture it is. So is it a compression or is it a burst morphology? You're gonna grade them on their neurologic, if they have any deficits. Deficits, I mean like, can one leg not move? You're gonna grade on the intactness or disruption of that posterior longitudinal ligament. And then, I mean, if you have to go there. So some red flag things, like we talked about the MRI. What is that image depicted of?
Subtle
Anesthesia. Huge. So think about bowel, bladder incontinence when you're talking about all those nerve roots for the chronic rhino, thinking of saddle anesthesia, thinking of leg weakness, red flags. You're gonna stack consult, get an MRI. Those ones will let you get that. Moving on from the spine, continue on the body. Root fractures hurt. Usually it's from like a blunt force trauma that you're gonna have a root fracture. You have to be cautious of the neurovascular bundles whenever you're worried about rib fractures, making sure that there's no pneumothorax or things like that. So whenever these patients are in your ED, you're also gonna wanna get like oxygenation saturations, check their vitals to make sure that they are not having any decline. Know that if your ribs are fractured and you're not gonna want to take deep breaths because it's gonna move and it's gonna be ouchy. And so they're gonna avoid it as much as possible. So you wanna try to coach them that they're gonna need to continue doing. See this in polytraumas more, they're a bed hospitalized on a bed, have rib fractures, get pneumonia. They don't wanna take deep breaths. So you gotta make sure that you're working on enough pain control that they can continue taking their deep breaths. You can miss stuff on x-rays. You can miss at least 60% of rib fractures on a chest x-ray. CTs are gonna be more sensitive studies. A lot of people that are coming in for polytraumas get multi-CTs, but unless Because most rib fractures are treated conservatively, meaning non-operatively. I wouldn't, if you're in the ED, I don't think you need to necessarily send them through a CT scanner for something that you're gonna treat non-operatively. I think your X-ray is fine as long as you have them with good clinical follow-up. But if they are somebody that has hypoxia, a lot of comorbidities, they're not your like young healthy fellow that just got punched in the ribs. Or if they are having like a large area of concern, or they're older, then they have a higher risk of morbidity. So I would get the CT scan for them. Another thing that we don't do a lot of, I think more conservative management for is your scapula. Scapula is a pretty big, thick bone in the back, kind of hidden. So it really takes a high energy of the trauma to do anything to break your scapula. A lot of times they're gonna have other injuries, like 90% of the time, you're gonna fracture a rib or a spine, or have some sort of brachial plexus injury as well, involved with your scapula. And commonly are gonna be your scapular body and the spine for your scapular fractures. There's different views that you can get. You're not typically tested on these guys either, but you can get different views, X-rays and CTs of your scapula. Remember to compare opposite side, but it's usually non-operative management. You're gonna maintain them in a sling. You're gonna encourage them to do early range of motion so you don't get any frozen shoulders. And if there's any glenohumeral instability or something like a displaced scapular neck, or heaven forbid, an open fracture, you are going to be going to the operating room. Clavicle fracture is next. This just makes me think of like a little kid skiing or skateboarding. I can't ask you guys medical questions like, did you do this when you were little? But a lot of people I know broke their clavicles when they were little kids. This is when you're falling straight on it. Usually, a lot of times they're going to be treated non-operatively in the immobilizer. This kids heal great. You want to have them do early range of motion. But if it is really displaced, like he is, they may need to have a fixation to align the bones back up. Things that you are going to be worried about here. Hey, it's pretty close to your lungs again. Are you worried about that patient breathing? Go in there. So things like hoarseness, dysphagia, upper extremity, you should make sure you are watching them and getting attention on them really quickly. So you don't want any injuries to their trachea or their lungs or their brachial plexus, thymus nerves. Moving down the arm. I've learned so much about splinting and casting. You can do most of them. If you're in the ED, just discuss a follow-up plan before they leave you, and talk with an orthopedic colleague if you have the option. Make sure that you set up their follow-up, be very thorough with that. Because you don't want anybody saying that you mismanaged them. You know, again, is anybody gonna ask me what a hip fracture is? Or you just all know what it is? You know. Yeah, with your finger. Toes. I just think of it as like tip of your finger fracture, finger fracture. I honestly like having that done. Because I don't ever see it. But it's a tip of your finger. And, you know, those non-displaced clavicles, again, you're just gonna sling them. But those could be all managed by your primary care. If you are doing your humerus fractures, these are gonna be your kiddos in a trauma or, well, what do you guys, have you heard of Boosh? Yeah. Falling on an outstretched hand for your elderly, fall down and go boom. What you gotta think of is, are their nerves intact? So make sure that you are checking the sensation on their arms as well. You're worried about that axilla and the radial nerve. depending on if it's a humeral head or a humeral shaft fracture. X-rays are great. Go through your classification, but we have it here for you. All based on, the proximity. Forearms. So your elbow is the formation of three of your bones come together, your humerus, your radii, and your ulna. Your forearms usually is falling or direct blow. I don't know, you're like fencing or fighting somebody and get a blow straight to your arm. It's usually they'll give you that description of their injury as this just happened suddenly. I've got now a ton of bruising and swelling, numbness in my fingers, things like that. Get an X-ray. You might need a splinter cast them. Consult if there's any displacement or if anything is sticking through the skin. Radial heads, the back side here. So if you see any fractures here, this is typically patients that are falling on that outstretched hand again. They're gonna have limited range of motion of their elbow. Tests love this one. Start. Tail sign. With that big interior backpack. See that, like this coloration there? Tail sign. Radial head fracture. You know what else is a great star page? This one. Have you heard of this guy before? Okay, I can read it to you, but you're just gonna have to memorize it because your tests love this. Big things here. Your Montegas, can be reduced. Usually they're gonna question you on the, like, where the fracture is, so if it is proximal or distal, and if it's your radii or your ulna. So with your Montega, your fracture is proximal ulna. The dislocation would be from the proximal radial cap. For your Galeazzi, it's gonna be a distal radius with a dislocation. Distal. There's some things that you just gotta memorize. So we'll practice these in a little bit. I'm not gonna make you practice it now because the things are literally right above it. But going through memorizing where your ulnar radial fractures and locations are. With your Montegas, think closer. Elbow. With your Glazes, think closer, wrist. Elbow, wrist. Elbow, wrist, wrist, elbow. Right hand blue. Left foot green. Another one they love are these Colles fractures. So, between your Colles and your Smith, it's most common to lay with your hand out like this. So if you're falling on that outstretched hand, so the Colles is most common. You are gonna see that nice little pitchfork bump. This is actually your Smith. Don't mind me. Here's your pitchfork. Here's your shovel. level for your Smith fracture. So that's if you're going down like this. I guess they're saying, Spade, Nancy. This guy's cute. My dog's like eating the dinner fork. Do you feed your dog with a fork? No? Yeah. I do sometimes. So with your collie structure, they, like the dinner fork thing, but I think the dog's cute. Never can help you memorize it.
The term dinner fork deformity is so often used as a buzzword in
Yeah.
questions, it's worth at least making that connection in your brain, even if it doesn't help you see the mags, right?
Remember this cute little guy? Hey, boy, we talked about these. If you are really worried about it, get advanced imaging. Why? Because they hide. They also don't show up right away, and it can be high concern for, here's your buzzword, AVN, avascular necrosis. Don't let it go for too long. All right. Metacarpal fractures. I'm sure you're getting multiple views. Again, can't stress that enough, but they love this one. Boxer fractures, if you're gonna be your fifth metacarpal. It's gonna be usually at that neck, the thinnest part of the bone where you're gonna get it. You know, so like pinky's turning in, maybe on a clinical image. And if they are angulating that much, you might need to pin it. But make sure there's no open skin. This is all the stuff that we got to play together before. Are you guys doing? Can we roll into lower extremity? Alright, we're going through. This side of the room, silly. Yeah, dim lights, everything. Mood lighting. Alright, so. Again. You can handle a toe. Pelvic fractures. So with your pelvis, you can get different views. These Judet views are inlet outlet views, like looking in out the pelvis. Those are helpful to evaluate your pelvic ring stability. You are, you know what I'm talking about when I say pelvic ring? Yeah, okay. You are going to consult on most of these too for pelvic fractures. It's gonna be, you're either gonna make them rest, so, or those love acronyms, WB, weight bearing. Or you're gonna have an external fixator, or you're gonna do a shoulder. They likely are not going to ask you classifications of your those fractures on your next. I mean, it's just because it's so specialty oriented, I'm gonna skip that for you guys. All right, but what is gonna be the area you're most concerned with? AVN here. Someone help me, I'm louder. Someone say femoral neck. Yes. Feels like head, but it's femoral neck. This area, skinny part. If you cut off there, you can cut off your blood supply. You are femoral head. In the femoral neck area, but for your, when we redo this, just a fun part, we like cut through here, we insert a cap here, and a whole, like this whole thing becomes a prosthetic. And then we'll put like a shaft. So as you get old, you get osteoporosis, and that's a lot of your little old ladies with your hip fractures. They fall, they go boom, and they fracture their hip. you can diagnose it on the X-ray, you don't need any fancy imaging. A lot of times you're gonna do a, hip replacement for them. But if it's a trauma, you could do some sort of nail or pin. You gotta be careful, because you have fractures in that area that are gonna be concerned for AVN, Tesla of AVN, because you don't wanna mess up somebody's blood or blood supply. Different, again, as you're explaining fractures to people, you can think of, is it displaced, right? Is it not lined up? Is it reduced, meaning is it able to be placed on top of each other, or is it not reducible because there's multiple components of breaks? Bring that, but we can go on to color fractures. They aren't gonna really make you know the classifications of fractures on these guys. Just know your soldier hairs. Patellas, your kneecap. It's controlled by your quads too. This is gonna be if you are falling down directly on your knee. What's the name of the X-ray? This.
Sunrise.
Yeah, I don't know why this is sky view. That's weird. Sunrise. Because it looks like the sun. They love that test question too, to make sure that you're being able to see the patella. If it's displaced, let's see again, no, if it's displaced, you are gonna be going to the OR and you might get something like this. A plate. But if not, they may just put you as non-weight bearing. Ankles. They love these ones though, know these fractures. So, your ankle joint is your tibia, your fibula, and your talus. Okay, this is, all head, this this joint, I can't pronounce things, but it's, your bones are being held together by your ligaments. Your anterior fibular ligament, this ATL ligament, is like the most common one. That ruptured. You can have fractures just depending on where, they can be classified as bimalar or trimalar because of what one thing. Right, it's either like 2 or 3 fractures, right? So if you are bimalar, it's a lot of times your medial and lateral malleoli, these are unstable, you're gonna need to get a instrumentation for them. If you know you got a trimal fracture, you're also gonna have that posterior malleolus involved, and you also are going to have an unstable fracture that's gonna require some fixation. But sometimes you can get away with a simple malleus being this bad in a bug boot that makes you not weight bearing on there. Get your medial and your lateral views. Have you guys heard of Ottawa ankle rules? Ottawa, yeah, no. They help predict your fractures in the ankle injury patients. Their guidelines for determining if you need a ankle X-ray. So basically, you're going to be looking to see if there's any bony tenderness at the posterior edge of the tip of the lateral malleolus, just because this is a common place for there going to be fractures, as well as the posterior edge of the medial malleolus. So you're going to feel on the inside and the outside bony prominences. If they're unable to bear weight, or if like they just told you something terrible, you're going to be making sure that you're going to be getting your use. This is more on those ankle rolls and why you get them. There's another view called a Monte's view, where you're able to see that AP view because they rotate the ankle. This gives you the spacing through the ankle joint. If you have, widening in that joint, it's gonna tell you about more, instability. The medial space shouldn't exceed 4 millimeters. Usually it's about the distance between the tibial field and the talus. Any widening of greater than 6 millimeters is going to be disruption of your medial collateral ligament. Here's another picture of that more teeth view. And here's what it looks like when it's big and wide. Right.
So this is a widened ankle mortise. This is a surgical repair or treatment. This is a very unstable ankle on the left. You can see how this is widened here. This is shifted over, right? This should probably be right here. So you can see that that is significantly shifted compared to this one. This one, you see there's a little teeny ossicle there, which is not unusual. And that's probably from an old ankle injury. It looks kind of smooth and oval. But this is a fairly, you could say, yeah, maybe that's a little wide, but in general, this looks like a pretty normal mortise compared to that. I think everybody can probably see that. And so if you get that ankle on the left, you get that x-ray, you need to put that person in the splitting and get them to your friendly orthopedic surgeon fairly quickly. They should not be bearing weight on that ankle, and they probably aren't going to be able to, but that needs a screw across that to stabilize that. And that means that we don't see any other fracture there on this ankle at the moment, but that means something else happened with an unstable ankle like that. That means there could be a ligament tear plus a fracture, and they may have a fracture higher up.
But, for foot fractures, your Jones fracture, I would say, is one of the more common ones that they love to talk about. How to start your Jones fracture. I don't think anybody's ever put an advanced fracture. The Jones fracture. That's going to be the base of your fifth metatarsal. When non-weight bearing. One of my best friends, she actually had one of these because she ran out from the ocean. She like started, like when we were younger, she like started out in California and there was like a divot in the ground. When she ran out, she like stepped into this giant hole, and hers was so displaced that she actually got surgery for this. But most people can be non-weight bearing in a boot cast, but if it is at gonna be not aligned or there's displacement on it because of the high risk of a non-union, they will do a surgical intervention. Here's your Jones fracture, there's the base. We love these ones too. Those Frank injuries. Have you guys heard these? Do you know Lisa Frank? Or is that like?
Oh, yeah.
Yeah.
Okay. So like Lisa Frank, for those that are like shade. About. Lisa Frank is like having these beautiful rainbows and unicorns and different things like this. That are, like,
Literally
super colorful art.
I was about to say.
Cool.
You're in school support.
Yeah.
Yes, I'm obsessed with this.
Those just won the 1900s.
Yeah.
That's this one. They're like iridescent and they're like really cute, like ugly pictures.
Frank injuries, I think of all of
Yeah,
the pretty colors.
It's so
that
funny, it's
blues
Briar in school
and
supply, yeah.
They actually love that like blue thing, buzzword.
Yeah. I love it so much.
But, you wanna make sure you are getting weight bearing x-rays to make sure that there isn't any displacement of those. It's usually gonna be at that second metatarsal that you are gonna see the displacement. Down here. And then past that. with those, you would do a ORIF perfusion. If it isn't displaced, then you don't need to, you can just not leave there. Here's how you do it. All right, to dislocation. You got this, so we'll show you some joints being out of place. I would not really do reductions in, if you're just straight up in the ED, I would call orthopedics to do your reductions. I don't know, what do you guys do? You do reductions?
And I mean, I work in urgent care, so shoulder dislocation, very unlikely, without some sort of sedative or anesthesia, maybe an elbow or knee dislocation.
I would say protect yourself, you're probably gonna consult on these, so I'm not gonna teach you how to reduce that unless you wanna like play with me at the hospital, but knowing just what is dislocated or what sublux was helpful, and the difference between a dislocation and a sublux. So a dislocation is when you're completely disarticulated from the joint. This is gonna be pretty obvious on your x-rays. It's just gonna be like this, where you're just like completely stuck out. Where that hip, that femoral head is no longer in the your scapula. There's a high risk of neurovascular injuries with the sublux, or excuse me, with the dislocation versus your sublux, where you aren't going to be as moved. Like you can just see how there's like more widening space there between that. This is where you're just partially disarticulated from the joint. It often reduces itself. They self-reduce and there isn't as much of an injury because you're not as far away from your normal anatomical limit. For dislocations, common joints are gonna be your shoulders. Your kids, they like tell you not to swing them by their arms. Because you can dislocate their elbows. So elbows a lot for kids, those dislocations, and then you know, my Instagram feed has been filled with like basketball lately since it's like NCAA. There was one of, you know, it all goes back to Kobe, and one where he like dislocated his finger at one point, and his trainer comes and snaps it back into place. But fingers are another common place for dislocations. Probably one of the most common places that I see dislocations, even though it's less common, is going to be the hips. A lot of times in patients that have had a total hip arthroplasty, they would not follow their posterior hip precautions, meaning they're like bringing their knees all the way up, but it's just putting a lot of pressure into that pot where they're going to pop their femoral head out of their socket. So got to worry about neurovascular injury with the big guys, your hips. If you have any knee dislocations, not so much worried about the neurovascular injury with just the patellar, because it's the kneecaps, just like right above. But for other structures in your knees, and then your ankles, foot, wrists. Or less, but make sure that you're worried about, or make sure you're checking for pulses and making sure no increase. My anesthesia friends, I call them, I ask them to give anesthesia or sedation to be able to reduce the joint. And the reason behind this is you want it nice and relaxed when you're doing reductions. You don't want somebody to be all tightened up because you're not going to be able to move that. If it is so rigid, or if it is somebody that has hardware in there or whatnot, you can do a closed reduction in the OR if you have to as well. If it's an open reduction, obviously, anything is going to go into the OR. Examine and document your neurovascular functions. Get films after and before. Make sure you immobilize them after you've done that, because you need the tissue to rest as well. You can use Also anesthesia for sedation, but anesthesia afterwards, or excuse me, beforehand too, with NSAIDs or opioids. Refer them to follow up if that is something that's done in the ED setting, because once you already kind of like rip something out, you now have instability there, and you want to make sure that they don't pop out again. You want to have them having a follow-up plan. Shoulder dislocation, shoulders are the most common dislocated the joint in the body. Baker and Hill-Sachs lesions, they love these. Again, you just gotta, think of like being like, put a hill. No bank. So these are your, whatever the Hill-Sachs are gonna be your infection of the posterior lateral clean-up head. Likely occur with dislocations. The Bankart's down here. Fracture of the anterior inferior glenoid rim, seen with anterior dislocations. Anterior forces with, your abductions and your adductions. Okay, so anterior force with arm and abduction. Your posterior dislocations are going to be with adduction or flexion. Which ones are more common? Pretty much just general rule of thumb. If you see most common, gold standard, those things, start. From Baba, get his, do you see him? Kind of watch this one.
He looks through.
Or like usually.
I've never seen that word one time in my life. Slow movement, like relocation, ever.
When you
Usually
able
it's
to
so
reduce a
violent.
dislocation, or like a nursemaid's elbow or finger dislocation with enough anesthesia, it's like really gratifying. You feel like pop back into place. It's a lot of fun.
But there's different ways. There's also, there's how to reduce our pain, traction. AC sprains or AC separations are, where you're gonna see that nice little fold on the shoulder. So especially when you're getting into higher, like, types, you're gonna get that separation where it's gonna really bubble up. Usually it's a direct blow onto the following, like on the tip of the shoulder, especially if your arm is abducted. You can get shoulder pain with arm motion. One of my friends did this by falling off of a bike. It's one of the most common upper extremity sprains. You are going to make sure these guys wear a sling, but then also make sure that they're doing mobility. Give them limits, have them go see somebody for a specialist for it, because what you don't want is a frozen capsule. Another terminology for that is adhesive capsulitis, where it's frozen shoulders and they can't move. Because most of these, it's all going to be the rehab after that you are going to have a operation for them. Hip dislocations. Here, you see that posterior is most common for these guys, though. High impact for traumas, you need a lot of, force to really force the big bone out of its joint. You are going to check neurovascular status, elbow dislocations, food. Get your x-rays. Do your classification as far as what direction it's gonna be. Do your reduction, recheck the vascularity afterwards, get repeat films. Do your elbow slings and or splits. Nursemaid elbow, kids, pulling. Give a history before trying to reduce. And they should be using the arm. Kids don't always give you the best history afterwards, but you should make sure that the kid is using their arm afterwards. Kids can use NSAIDs or things to help decrease their inflammation. Fractures of the wrist and the hand. This is a nice little summary. 4 different pictures that you're gonna see. Boxers fracture, again, think of it down here, one of the most common in that area. When you are thinking about your scaphoid, think about your, avascular necrosis. They may ask you, your pretty much like boutonniere's deformities, where you're gonna have an injury to the central band or extension tendon. I would say that one's more, I don't really think that they do as much regular things with them, but I also don't rate their bands. But I don't think they're gonna get you too much. We talked about the scaphoid again, ABN. Here's your little pointer tip fracture. Tops. Here's when your pointer tip is going into hyperflexion. Here you go, mallet finger, baseball finger. Mallet finger, baseball finger, hyperflexion. Pointed down. Get an x-ray, make sure that you're not having an avulsion fracture. Split them. Don't do surgery. Boutonnieres. Now you've moved down to the bigger button of your, impacted the side of your flex at the PCP. It's gonna be your extensor tendon. Boutonnieres deformity, extensor tendon injury. PIP joint. Split. Gamekeeper's thumb. And that gives you like Sears thumbs, thumb, you're falling. I think we got more with. Boarding. That a lot more. Abduction, ulnar collateral ligament tear. Ulnar collateral ligament tear, gamekeeper's thumb. All right, I'm gonna give you guys another potty break. We're rolling through it. Let's do another 10-minute, because you guys are gonna take 15 minutes to get settled, so another 10-minute, and then we'll go into some areas. But you can't get the whole picture of the board. You can't see any like myelomylation changes or like whitening on it, so if you're worried about a cord injury, get in the right. Get the views, know your views. You're gonna get your odontoid views when you're worried about the C1, C2. And if you are trusting the patient to stay in their brace, just make sure you have close follow-up with their spinal surgeon. For your thoracic and lumbar, your APs, your lateral. If it's behind the scapula, get your swimmers. So swimmers is another type of thoracic spine view. It's like shooting underneath here to move the humeral head out of your way so you can see the thoracic, upper thoracic vertebral bodies. And then your CTs are going to show you a little bit more for those, yes.
So you're having a patient raise their arm out, that's over,
You should
What-
hear.
they're mobilized. They have spinal cord injury.
The C collar?
Yeah.
You can still lift. Even if you're in a CTO brace, you can still lift your arm out. A CTO brace like takes, it's a cervical thoracic brace, so it takes you from like here it attaches to like a chest plate, and then it goes in the back. You still have freedom of your arms. Or somebody can pull in for that too. A lot of times if they're that far down, they're getting a CT anyways. But I make them then get upright x-rays. Why? Yeah, for positioning, because I wanna see how they right folks over. Or how they are weight bearing. Your indications after a trauma, I mean, they're gonna be getting these injuries, they're gonna be getting, the imaging anyways. But if they have midline back pain, focal tenderness, any deficits, please make sure you get them an image. And also watch for any vascular injuries as well for those. Your spinal cord injuries, this is gonna be your little star slide. They like asking questions on anterior cord, central cord, ground guitar, things like that. You guys go over these before.
Once had a patient who had a left-sided Brown Sequard,
Mhm.
and he was coming in with vomiting, fever. Turned out he had appendicitis, but he wasn't able to feel pain in his appendix. So that was an important piece of history just to gather.
I personally have essential cord syndrome, so I've had affected with my fingers and my upper extremities, so when we talked about in patho. So it's especially like in the gripping, and then sometimes I have issues with like temperature sensation in my lower extremities.
There, I have a point of reference, and you're not gonna forget it. Central cord. This slide says possibly an older patient, possibly very old. But the reason for that is just because people, when they get arthritis, their bones build up and they get so much stenosis in that area, which they can get then compression in that central part of their spinal cord. But if you are thinking central, think the upper extremities are going to be affected more than the lowers. Anterior cord, think of it being bilateral loss of motor below the level of injury, but you're gonna have intact vibration from proprioception. Brown Sequard is gonna be only one side. And if you remember from your anatomy and biz, your differences in where your sensory and your motor nerves, because of where they cross over in the brain and spine. You're gonna have ipsilateral or same side loss of motor versus your sensation is gonna be on the contralateral side. Um. I don't know. If you suspect that there's an injury, make sure that you are getting a complete assessment, including the airway, if you're considering it being cervical. Or 3, 4, 5, keep the diaphragm alive, if it's fracture about C5. Make sure you are protecting the airway, you might need to have them intubated. The stuff that you learned before with shock, make sure you're fluid resuscitating. Keep the pressures high, so the way your spinal cord is perfused, you need to have higher naps or higher mean arterial pressures. With that, they're gonna bleed too, but you might use both getting them reperfused with more blood, as well as keeping their pressure high with nootropics or with steroids. Consult if it's that bad. How do I point went over this horsetail buzzwords, saddle anesthesia. They're gonna need decompress. Timeless nerves. Get them into the OR. Going over chronic sinus syndrome again. You just need like MRI stat. You don't need to get X-ray, you don't need CT, just MRI. The sagittal and axial, those just are the views that you just need to know. When you order an MRI, it comes with both sagittal and axial cuts. T1 and T2, that's how the images are weighted. But just no MRI in surgical decompression. Acute lumbar disc herniation, NCC, anytime you see most common cause, start. Rhabdo. Bodybuilders. Is CrossFit as big now as it was like years ago? Okay. Well, some people maybe decided to get really into fitness when they weren't into fitness before. Usually that's gonna be the story or the hallmark that you have for these patients when you're on an exam. Those are muscular injuries where their muscle fibers are rapidly breaking down. And you're releasing all of these, where you're gonna see the blood creatinine kinase go up. You're gonna see protein, myoglobin in the urine. You're gonna have dark tea colored urine. These patients need a lot of fluid resuscitation to protect them from going into kidney failure. And since the kidneys have so many byproducts that they have to filter through, kidneys love fluids. You have to give them a lot. Another common or another mechanism of injury is going to be your crush injury. So like somebody like switched under a car could be another one. Okay. Here we go. More information on that. And, oh, look, cut CrossFit, speak age. Compartment syndrome. And so this is when you are having the container is just way too small. So it's limb and life threatening because you could have all of, if you don't have an early fasciotomy, you're cutting and opening up, releasing that pressure. You can have the injury just like it becomes where you don't have any vascularity to the area. They're going to teach you the 5 P's. I like this picture a little bit better for it. Pain, pulses, if you're losing any pulses, pallor, where you're starting to see the white paresthesias, or if they can't move it, those are your P's. You can think about it as for most common, you see like people with those big cuts on their shins. The lower leg is a pretty common cause of that. This is going to be your long bone fractures or your thrush injuries. Sometimes it takes days for these things to develop, just depending on how much swelling in the area. Most sensitive physical exam finding is pain on passive range of motion, the stretching of the affected muscle group. The way we test for these things is this fun little Stryker gauge 2, where you are checking their compartment pressures. It's so if there's any swelling or bleeding in that compartment, it becomes like the fascia doesn't stretch with it, so the container is too small, and then the capillaries, the muscles, the nerves in that compartment don't get the same amount of blood flow. And it usually doesn't happen where everything dies if it is more chronic. Like there's one of my residents right now is getting a scheduled fasciotomy. He has some form of compartment syndrome in his calves. But it's more of like the timing of it's so acute that it would be more limb threatening for that. It can happen everywhere, happening to the butts. Most commonly lower legs. Fasciotomy, so basically splitting or opening up. Just your patients like this. Sometimes we'll, like a little bit with what's called a Jacob's ladder. You'll see like red little things going across. And they'll end up closing up once they're falling this down. Here is that machine. This is the striker gauge. Girl, really happy.
Which is the difference between the diastolic
Oh, no.
clear out the air in the chamber by injecting the saline into the chamber. No air bubbles are allowed, and you do this holding it at 45 degrees. And you may have to give it a little bit of an aggressive flick, like a subungual hematoma kind of flick
Oh, no, I really don't know if I like.
into the compartment. You might feel a pop as you go through the fascia. Inject about 0.3 ml of saline, and now it should read your compartment pressure. You know you're in the right place because if you squeeze that compartment, you'll get a rise in the pressure. The pressure is over 30, so this is consistent with compartment syndrome, and I think he's gonna need a fasciotomy. I'm sorry, sir. So how about now we review
other
the
kind of
anatomic compartments? The lower leg has
No,
two
not the hand
compartments
position.
that Dr. Hamoud has volunteered to help us demonstrate. For all of the compartments, you're gonna go at the imaginary cross-sectional line about 1/3 the way down the tibia. For the anterior compartment, palpate the tibia and go 1 centimeter laterally. Insert the needle 1 to 3 centimeters deep, and the pressure should rise with plantar flexion of the foot. For the lateral compartment, palpate the posterior border of the fibula and insert the needle just anterior to the. It's aiming right towards.
When you think of long bones and they break, I think you gotta be concerned with that emboli. That's where a lot of them are concerned with trauma and they kind of, especially with female fractures. That the flat embolus could be reason up towards those limos. It can present in the lungs, it can present going towards the brain, the heart. Those are the important things that we're worried about with those. They're gonna need supportive care wherever the emboli is going. But really hard to prevent because they came in with this fracture beforehand. Penetrating traumas, document. Update their tetanus, make sure you're removing any foreign bodies. One thing I'm gonna say for this one is, we don't really go after gunshot wounds. Why don't we go after gunshot wounds? Nobody? Yes. Why don't we go after gunshot wounds? Like, why don't we
Like,
go
why
after
leave
the
them
bullet?
alone?
Oh, why don't we like go ahead and look for it?
Like, if it's like lodged in the spine, why am I not gonna go?
Oh, we're doing a lot of things around.
Yeah. With, and it can like go off, like something else can go on, so usually leave those alone, but for other penetrating trauma, make sure you're, removing the foreign body. And getting there, did tetanus. For septic joints. Unfortunately, our IV drug users, a lot of these guys or are immunocompromised, if they had a recent surgery, things like autoimmune, all of those, if you hear the news stories, kind of concerned about a septic joint if the patient has, swollen, febrile, or if there's, have a swollen joint and they're febrile, you're going to get labs. You're gonna see a lot of times, them doing, what you would want is getting a sample of the joint fluid. So your white count is gonna jump up above 50K. You might see a high lactate or LDH in that as well. And the cultures, they'll usually populate a bit pretty quickly, but it may take you a little bit of days back to get a, differential on your, septic joint. So if you're thinking about a septic joint and you're worried they come in, some things that you're gonna be, on your differential diagnosis are what? If it's not a septic joint, it could just be,
Cellulitis.
yay! Are you reading the list?
Yes, yep.
Gout, pseudo gout. Think of, you guys have done gout and pseudo gout before?
Mhm.
So negatively, positively, by Christmas, know those. Arthrocentesis is you're taking a stab at that, pulling out some joint fluid. Cellulitis is gonna be normal. I help out soft tissue a lot too. And the differences between cellulitis and necrotizing soft tissue infections on CTs. Like, get a specialist for sure, you're gonna consult them because it can be tricky. Yeah, negatively by fidget, that you need to know. I'll test you on that. Here's common joint things, just know you're gonna have a high weight count. Know the crystals, but don't get yourself too bogged down in the numbers on there. If you're worried about a septic joint, make sure that you are giving them some IV antibiotics. Here's some common things to do. The ortho is gonna be doing your tap. Again, there's that chart. I wouldn't get too bogged down in the numbers. But know that your pick is gonna be positive for the septic joint. You know, the crystals on the other one, you know, you're gonna have it be cloudy. Okay, because it's deity, and you're going to have those white cells in there. If they start talking about sexually active things with a prodrome, and migratory polyarthralgias, think gonorrhea. No, you're gonna be doing azithromycin and cetrax, so it's usually a single joint. Writers, another one, anytime you have a syndrome and you have those things, can't see, can't pee, can't find a tree. Did you guys see that one? Okay, you got this. Those are classic triad symptoms. So that's where you have your arthritis, your conjunctivitis, and your arthritis. Osteomyelitis. This is your infections. What study is gonna be most important on those? Here, give you a hint. Right. 6 to 8 weeks. Antibiotics. How do you know what kind of antibiotics to give? You gotta get bug, get cultures. What is the most common? Yeah,
Staphylococcus.
beautiful. Okay. Urgent things. You might see these more. Know that sprain are gonna be your ligamentous structures, strain are gonna be your muscular structures. All conservative. Tendon ruptures. If you have a quadripatellar tendon rupture, I do see You know, you can stabilize them in like a hinge knee brace locked in extension, but they are likely gonna need, some sort of fixation. And the recovery, can be tough. Usually the quads are older. The tellers are younger guys. Thompson test for Achilles is another little star. So that's when you're having them lay down. Actually, I'll show it to you on another slide. But these are your Achilles ruptures. Your basketball players, stop and go. Fluoroquinolones is another one. Buzzwords where you hear it pop. Tendon ruptures, the Thompson test is when you're gonna be having them lay down. If you can squeeze and there's no response, then, you know, there's gonna be a disruption there, so that would be your positive result from that. Tricep tendon rupture, Popeye. Popeye. A lot of times you can be conservative with these guys, but you also, can have surgery if it's something that's like, been severely affecting them. All right, you ready to do some Salter Harris classification?
Yes.
Who's have the answers on your thing?
No.
Ooh, no snap. Okay. What are you guys thinking? Salter Harris, where are we going?
Which one?
Sorry, that's back there.
No.
Well,
Oh, it's probably type 2.
all right, we'll go.
Okay, tetanus.
Okay. I don't know all the buttons. but,
Tetanus, actually.
Should answer this up for that.
let's do-
Yes.
there.
Enough. Better not make me diagnose.
Okay. Skipping through. I don't know how I should get this cleaned up.
Use the pencil.
All right. Oh, here's the Salter Harris question. We did pointers. We'll do more. Okay. Describe this guy. What else do you want to get done? What do you need to see to be able to? help you
Lateral,
diagnose
CT.
this?
Lateral.
Another view. Here's your other view.
Oh.
Oh.
Not good.
Carpal, metacarpal, carpal. Dislocated fifth metacarpal.
Very nice. Okay,
Oh, yeah. Wouldn't it be the carpal, not the metacarpal?
here we go.
No, your carpal, your little ones.
Yeah, these are the minutes.
The longer ones. Oh, yeah.
All right, here are those guys.
Like your ski-
Remember that mugger. So
Oh,
for this
ulnar
one,
fracture.
which one are you thinking? Is it the Montega or the Galazi?
Montega,
Good job. Which is a fracture of,
the ulna,
and a dislocation of.
radius.
Good job. Is it on your feet?
No. No. We're just so smart.
Okay, here about this one. Which one?
The Lizzie.
Montega or.
The Leslie.
I don't pronounce anything either, it's the big one, right? So it's gonna be a fracture of a distal.
Radius.
Yeah. And a dislocation of your
Oh,
real or, yeah. Nicely played, nicely played. Okay.
Kind of a good hot dog. That's really bad.
Is it what direction of a dislocation?
Posterior.
Good job.
Which one is it? Posterior?
Posterior. Why is it a posterior?
Michelle said
Little aspect is like that.
I never had anybody that just told us.
Dislocation.
Yeah.
I am. Okay. How would you classify this fracture?
I'll try now.
By.
Try malleable.
Yep, a trimal. What are fractured in the, what all
Lateral,
is fractured?
lateral and medial malleoli.
And posterior.
Yeah. All three, what are all three?
The malleoli. Lateral, posterior.
Yeah. Medial, lateral, posterior. All right, y'all. I'm gonna give you 5 minutes of questions. Anybody have any questions? No? Okay, then I'm gonna give you 5 minutes of your life back.
Really sweet.
I mean, what do you think here? It's gonna be a 5